And we're going to open up to some Q&A now. If anybody has any questions, please either raise your hand and we'll bring a mic to you, or if you have a card that you want to submit, and I actually have some questions online, so I'd like to open it to the floor. Any questions? Hold on one second for microphone, please, in the front. Thank you. Please raise your hand so they can bring you the microphone. Thank you.
Message for Dr. Ilson. Dr. Ilson, you did not mention right now very huge amount of literature coming about stem cells. So my first question, what's your opinion, how it can integrate in treatment of stomach cancer? And second question about new influence in American medicine due to opening in Washington, D.C. under leadership of Dr. Johnson, doctor of naturopathic medicine, treatment people with cancer and having positive result as per statistic. What's your opinion about this?
Yeah, unfortunately, stem cell therapy really is now mostly for blood-based cancers. There's no application yet for stem cell therapy in stomach cancer. Yeah, there's no really controlled studies yet. I mean, I know there are some, sort of practitioners that are giving patients so-called stem cell therapy, but there's really nothing that's been subjected to real established clinical studies. So I think in the vast majority of cases right now, stem cell-like therapies are really reserved for treating blood cancers, not really ready for any application for stomach cancer yet. I'm not sure what your other question was. Yeah, well, we're going to have a lecture later today about complementary medicines and supplements from my colleague from Sloan Kettering. We often use complementary medicines and supplements to help relieve side effects and improve quality of life. Things like diet, exercise, supplementary therapies that may complement but not necessarily replace conventional therapy. We'll talk about that later.
Thank you for your question. I have an online question here. It says, are the doctors aware of any immunotherapy drugs and or targeted therapy drugs that have been successful in producing a permanent or at least long-lasting remission?
So that's a great question. And you'll hear about this a little bit later from Dr. Janjikian, who was one of the lead investigators on a trial that looked at a combination of two immunotherapies, one that inhibits a PD-1 and the other that inhibits a CTLA-4. And there are actually, in fact, several studies that are actually will be resulting next year looking at inhibition of this axis in gastric and esophageal cancers. And it is indeed remarkable that although the proportion of patients that actually have a dramatic response to immunotherapy is not as high as we would like, it's maybe about 15 to 20%. Those that do respond tend to have a prolonged, durable response. And so we don't have like 2, 3, 4-year data yet for most of these patients, but once activated, the immune system does seem to control the disease for quite a long time.
Yeah, it does seem that in that small percentage of patients that respond, maybe up to half will get a benefit beyond 10 months. So whether or not those remissions are more durable, but certainly the real question for us is to identify who those patients are, because when we've got treatments that don't work in about 80 or 90% of patients, we want to identify which patients have the most likelihood that are going to get benefit from these new therapies. But there's a lot of hope and potential in a small subset of these patients for more long-term benefit.
I have a question for the person on my right and the person on my left, because the person on my right is a very broad histologic and genetic heterogeneity to gastric cancer, told me it was not one disease. And yet the person on my left told me that we treat all of these patients the same. And so the question to both of you is there any signal from clinical trials that one type of gastric cancer should be treated differently from another, given the tools we have right now, not the tools we're going to have tomorrow? To both of you.
Well, my lecture was on chemotherapy, which is the old-fashioned technology. And I'd have to say there is really not convincing evidence that the subtypes of, whether it's esophagus or gastric cancer, that they really respond that differently to chemotherapy. So maybe the diffuse type of gastric cancer may respond a little less well, but we haven't gotten a clear signal that histology dictates a benefit from chemotherapy. Maybe the taxane issue with certain subtypes. So for chemotherapy treatment, that doesn't really guide the choice of chemotherapy. For targeted agents, then we're getting more sophisticated and looking at abnormalities that may guide targeted agents. But for chemotherapy, that's not yet playing a role. And I didn't mean to make it simplistic, but I think the choice of chemotherapy is pretty much the same across the board, regardless of the tumor location or the histology. But Manish maybe can comment on the targeted therapies and immunotherapy.
Yeah, so thank you. So Dan, thank you for being in between us.
I've worked with both of them for a long time.
So, yeah, David, I think he said it very well, that, we think of chemotherapy as a blunt instrument, and we think of, we're now refining these subtypes of gastric cancer, and the targeted therapies we think of as a way to leverage the nuances. And so the first foray into this is Herceptin and HER2 positive disease. And, although that itself is a marker, we know that proximal intestinal and stomach cancers have a 30% rate of being HER2 positive, and diffuse gastric cancer less than 5%, and some people say it's actually not diffuse if it's HER2 positive. So the subtypes do actually, in fact, indicate what markers may be beneficial. We just need to be smarter about attacking the correct subtype with the correct biomarker. David mentioned, for example, the MET studies, the studies that inhibited the MET axis. And unfortunately, both 1,500 patients were enrolled on 2 large randomized studies. They were both negative, and in part because they weren't very well in terms of selection of patients who were driven by MET. And I think that's kind of a lesson. The very, very first anti-angiogenic treatment was bevacizumab in chemotherapy, and there was a slight benefit in some measures of efficacy, but again, it was in an unselected population. So I think the field needs to catch up to sort of say that we need to select patients who we're going to attack.
I mean, there have been attempts in stomach cancer to look at markers in the tumor that, is this patient more likely to respond to a platinum drug? And there was a lot of interest in a marker called ERCC1, and that really hasn't panned out. That ERCC1 testing may not predict who's going to benefit or not benefit from platinum. So there still is a lot of interest in trying to look at markers in cancers that may predict benefits of chemotherapy, but it hasn't been too successful yet, unfortunately.
One second. Can you use the mic, please? Thank you.
My question to any doctors: do you have biological markers for stomach cancer? Number 2, stem cells have very positive result not only in hem oncology but in treatment of DM, diabetes mellitus. And my next question, if you have such a positive effect of using Taxol, what we know historically Taxol used for treatment of ovarian cancer, why not use other drugs instead of putting so much money to create new drugs for pharmaceutical companies?
Well, the Taxol question, that's pretty, Taxol is Taxotere is an approved drug to treat gastric cancer. It actually was validated in a clinical study. So Taxol was, I think one of the first approvals was in breast and ovarian cancer, but not Taxol per se, but Taxotere is FDA approved for treating gastric cancer based on survivors from a controlled study. And we also know that using taxanes as a backup chemotherapy is helpful. It's modestly helpful. I wish I could comment more on the stem cell issue, but you know, it's just not ready for prime time. You know, we can't just look at anecdotes or, you know, isolated things that may seem to help one or two patients. You really have to look at studies, controlled studies that really address whether or not a new therapy is going to be helpful. And when you think, you know, what stem cells really do is they try and replace sort of, you know, normal tissue. So, you know, a diseased pancreas, maybe we can give patients stem cells so they can regenerate their pancreas. It's hard to understand how stem cell therapy would help a metastatic gastric cancer because you're not really replacing something. So yes, I think it, you know, it's something that merits study, but stem cell therapy, unfortunately, just not ready yet for any kind of clinical application in stomach cancer, not yet.
Maybe I could add to that. So, you know, what I think Dr. Ilson's talking about is the high dose treatment where you give a high dose of chemotherapy and then you burn out the bone marrow and then you replace that with someone else's bone marrow to then repopulate. And that's really for the liquid tumors. There is lots of literature on cancer stem cells. And there are now drugs, you know, sort of attacking cancer stem cells. So one that is made by Boston Biomedical, which is one of the sponsors of this foundation, or at least this forum, is they have a STAT3 inhibitor, and that's in phase 3 studies looking at affecting stem cells with chemotherapy. But it's specific to cancer stem cells, not the stem cells that reside within the bone marrow.
Yeah, cancer stem cells may be the real resistant population. Yeah. So, you know, we kill off a lot of the other cancer cells, but cancer stem cells may be very resistant. But that's not, that doesn't mean we have a therapy where we give patients stem cells,
right,
where we're targeting the cancer stem cells, and that's a work in progress.
We have another question up here in front.
What would be your next line of management after a patient underwent all this Xeloda with oxaliplatin, trial of immunotherapy, when the next line with Taxol and Cyramza and still failed, survived surgery for the gastric perforation, still unstable right now, but should she survive this, what will be the next line of management?
So it's very difficult to, you know, sort of think that through because so many factors play a role with regard to what the options are. I mean, I think that there are many clinical trial options. Dr. Rajdev is going to talk about clinical trial options that are available that may be targeted or may be general. But I think for an individual, you know, case, what you're describing is sort of a heavily treated patient who currently, you know, is recovering from a perforation. So I think we have to sort of see where that person sort of lands in terms of how functional they are before thinking of the next step. So it's really hard to sort of answer that in this kind of a forum.
And I mean, Dr. Lakshmi will talk about this, but, you know, a clinical trial is not the right choice for everyone. I mean, if you know, remember, clinical trials are looking at an untested therapy, something that maybe has unpredictable side effects. And if somebody is really very ill and compromised from the cancer, you know, we take an oath to do no harm. So we don't want to expose patients to treatments that may be harmful without a clear benefit. And certainly we are sometimes willing to take that risk when patients are strong and fit and they can tolerate the rigors of a new therapy that may have side effects. But when someone's more compromised and been through a lot of treatment, they just, you know, we don't want to kill someone with kindness, and you know, to actually continue treatment is not always the right answer. Sometimes, you know, quality of life and palliative care, focusing on giving patients the best quality of life possible, rather than actually treating the cancer, because the answer to the question isn't always what's the next treatment. It's what's best to make the patient's quality of life better and support them through a difficult time, and it's not always a treatment, but it might be more of a supportive care.
There's the mic.
I just sort of want to respond to that question. If this patient makes a very good recovery, and let's say this person is functional there is a national trial known as a MATCH trial, which does genomic analysis on the cancer, and since this patient's had surgery, tissue might be available, and then they match drugs to the type of genomic expression that the patient has. So that might be a potential opportunity if this patient makes a very good recovery. Now, the patient's received multiple lines of treatment, so I think that you have to be cautious and really be sure, as has been mentioned previously, that sometimes the better option is to do no harm, and people can actually live longer that way. But if a patient makes a very good recovery, the MATCH trial would be a good study for someone like this.
Question, because nobody asked. This is to you, Dr. Coit. One of your colleagues got in Sloan Kettering Hospital Nobel Prize in medicine, unfortunately post-mortem. He got Nobel Prize and he died day before we advertised. So he used to treat his fourth stage of tumor of pancreas by antibody. Can you make some kind of comparison? Can we use his method? Instead of living 6 months, he lived over 4 years.
I mean, antibodies as therapy is a very broad category. So if we, again, you have to sort of look at trials, trials that have looked at antibody therapies. So some of the antibodies that have been looked at in big clinical trials, and I mean, it's a gastric cancer form, but in pancreatic cancer, drugs like Avastin and Erbitux didn't help the outcome compared to chemotherapy alone. So antibodies are also immunotherapies, and we're not talking about pancreatic cancer, but immunotherapy has largely been almost ineffective in pancreatic cancer. So it's not just antibody therapy, it depends what the antibody targets, and we have approved antibody therapies in stomach cancer. We've got Herceptin, which is the HER2-targeted antibody. We've got ramucirumab, which is the VEGF receptor-targeted antibody. And now we've got a number of immunotherapy antibodies that are in late-stage clinical trials. And actually some results from Asia for a drug, nivolumab, which I guess the commercial name is Opdivo, a trial in Asia which looked at patients that had progressed on all conventional therapies and compared nivolumab, Opdivo to supportive care, and it showed a benefit. So there are very encouraging data for immunotherapy treatments in late lines of therapies, but antibodies are not one size fits all. Antibodies are a very heterogeneous class of drugs, and we've had success and we have approval of some of such drugs, and we are using them.
We have a question in the back.
So I have to admit that I am confused this morning because I had understood that a patient diagnosed with stage 4 stomach cancer in the upper GI, near the GE junction, with liver metastasis was not a surgical candidate. And yet I'm hearing from you that that person could have been a surgical candidate, and I'm hearing from Melanie Vincelli that that's exactly what she had. And in fact, she even had lung metastasis. So could you try to clarify that for me,
The
please?
vast majority of patients with stage 4 stomach cancer are not candidates for surgery. I think I tried to make that point clear. Yes. I don't think any of us are advocating for surgery as upfront management of patients with metastatic gastric cancer. And I cited a trial from Japan that showed it didn't help. However, I also tried to emphasize is this is a very heterogeneous disease, and patients have very different natural histories. And there are situations, and probably the best application for surgery is going to be somebody with initially locally inoperable cancer who responds. It's going to be a rare patient with liver and lung metastasis that we're going to push for resection of the stomach. So, and that's, but you don't like to ever say never. I mean, everybody is unique, but I think what you're misunderstanding here is you're thinking I'm promoting stomach surgery on everybody with metastatic gastric cancer. That's far from the point. You have to make a decision on each individual patient, and you want to use your judgment and how they're doing. And if you think a patient is going to benefit from gastrectomy, you consider it as one of the treatment options. But at the end of the day, that's probably going to be less than 1% of patients. So I was not promoting less than 1% as a treatment standard.
I just add to that because we struggle a lot with this. Emotionally, we're all kind of attached to surgery as the pathway to cure. When someone comes with metastatic cancer, their initial treatment is systemic therapy. No one should argue with that, and this clinical trial completely supports that. As your ally in deciding whether surgery is going to help that person. If over the course of treatment they have a complete response to all metastatic disease, so no discernible metastatic disease, and they have residual tumor in the stomach, then I think that's the patient we consider for an operation. That's like taking stage 4 and going back to stage 2. That's a very uncommon event. Much more common would be a complete response everywhere, in which case surgery is probably not going to help, or an incomplete response everywhere, very incomplete, in which case we're still stage 4. But there may be these exceptional patients, and boy, are we on the lookout for outliers, which is it's fine, and it's our job to recognize the outliers of the person who's had a complete response to the one thing that made them inoperable, which was distant metastatic disease, but still has residual tumor in the stomach. And I think we'd all recognize that these are very uncommon patients. We feel a little bit uncomfortable taking the stomach out of somebody who has no residual tumor in the stomach, because that might be the small single-digit complete everywhere to non-surgical treatment. So it's not, as David said, it should not be up front, but it never means not ever. Yeah, and I think I hope that clarifies it, because this is not a one-time decision. This is a continuum of decision amongst us all. Yeah.
We have time for 2 more questions, 1 or 2 more questions.
The prior question actually kind of was a good, actually answered a lot of my question anyway, but I just wanted to bring up now that we're doing cytology before, as a part of staging, and so there are going to be those patients who only have cytologic positive disease. What do you do with those patients? Obviously, they're now classified as stage 4, and they sometimes will, and so you do go on to a systemic chemotherapy regimen. But what do you do with those patients? Sometimes they don't progress. If they do, then obviously, they do. But what do you do about those patients who don't progress? And at which point do you think about starting to intervene or rechecking their cytology?
Well, I think that's a great question. It has to do with this very limited or minimal stage 4 disease. And we've been interested in this for a long time. And it's pretty clear that if you find positive cytology with conventional laboratory techniques, those patients do behave like stage 4 disease, early stage 4 disease. Most of those patients go on chemotherapy for about as long as they can tolerate first-line treatment, which, as David said, is about 6 months, 6 to 9 months. And then we look again, and we look if they still have disease, they're still stage 4, and they're going on to second-line therapy. I think the real challenge is if they've cleared their stage 4 disease, it was pretty much the same answer, is when do you intervene? And our experience is if you intervene at 6 months, those patients will act as if they will start to, in general, they will succumb to disease. You've stopped the treatment that works. So it probably 6 months is not the right time to decide, and maybe it's a year. Again, they still have tumor in the stomach, but clear cytology. But I will tell you that and I've got 3 decades of looking for this outlier patient, not just 2. We don't have one yet, okay? That if you have unequivocally positive cytology, we do not have a person who we feel has benefited from an operation. We have some long-term survivors, but I think that's been from chemotherapy.
Yeah, it's a very controversial area because there are some advocates that push for surgery and peritoneal chemotherapy, and it's better if you heat the chemotherapy. So there's a lot of controversy about this. And I think from our own institutional perspective, when we've looked at decades of outcome, maybe we prolong survival or delay progression, but it's not clear it's really whether it's a curative paradigm.
And there's a big hit to quality of life. Nobody's quality of life is better after taking their stomach out. Nobody.
So just a caveat to that is that...
Sorry.
So
Please do, yeah.
No, well, nobody's arguing that there are clearly patients that benefit from aggressive intervention.
Yeah.
But you got to look at what's the roadmap for most patients. And none of us on this panel are going to say we're going to deny surgery or other treatments to the appropriate patient. It's just, you look at the Japanese trial where, they operate on everybody when they walked in the door and they couldn't show a benefit. So it's not something we should do up front.
Right.
But it's not saying we should never do it. And it's not saying that there aren't patients that are going to benefit from more aggressive interventions. It's just you don't want to prescribe an approach to everybody when it's going to be individual patients that are going to benefit. But we got to select those patients carefully and not subject the vast majority of patients to interventions that aren't going to help them.
So the other side of that coin, so I think what we're trying to say is that this is kind of where the art of medicine is with regard to these patients. So actually Dan and I, we published a series of 30 patients with positive cytology and looked at this, and some of them had surgery, some of them didn't. And in that paper, what he said was correct, that there wasn't someone that was sort of a long-term survivor, but there was a delay, as David's suggesting. And so another idea is that you can't be on chemotherapy forever. And so if you are able to eradicate a site of disease, if the cytology on a subsequent look is negative, you may buy a window where that you're not getting chemotherapy, although you have to take the caveat of, is it, you do take a hit on quality of life, at least for the near term. I think long term, your quality of life sort of catches up a bit. So I think that these are individual decisions. I think that and actually this is probably a great segue to the idea that a multidisciplinary tumor board management approach is probably the best approach, because you get perspectives from all different angles to sort of say, how can we help this individual patient?
Thank you. One more question, and then we're going to move on to lunch.
Stage 4 gastric cancer who's responded well to chemotherapy, very well actually. What is the inference as to how that chemotherapy is improving any kind of metastasis, particularly peritoneal metastasis?
Yeah, I think your question is if the primary response does the metastatic disease. It's certainly a good sign if you see good response in the primary, and it probably is translating into a benefit at the other sites of disease.
So it's reducing and improving the quality of life the same as a gastric tumor itself might be improving the quality of life.
Yeah. Yeah.
Thank you.
Yes. 1.5 years ago, I had a radical gastrectomy operation. It was successful, but I've been through many rounds of chemotherapy. The last 2 of them, it was a combination of 5FU versus oxaliplatin. Then 5FU alone. I had a lot of problem with it, like side effect. The doctor decided, to take me off from chemo recently, from those 2. And actually, I'm wondering, what are my next options, since, I wasn't doing well with the chemotherapy. The doctor took me off. What are my options?
Probably take that one later.
Well, you know, I think if the cancer is controlled or stable at the current time and we're not tolerating current treatment, certainly oxaliplatin you can't get forever. I mean, we didn't get into the nuances of how these treatments are administered, but oxaliplatin typically you can get for about 4 or 5 months, and then you have to stop it because of, you know, neuropathy and nerve toxicities. 5-FU, many patients will, particularly the infusion 5-FU, the 2 days every 2 weeks, will tolerate as a chronic treatment. But there are patients where it just becomes intolerable because of fatigue or GI side effects. And it really depends on what the status of the cancer is. If it's minimal disease and it's not progressing, there are occasionally patients where we give a holiday from treatment and just watch the patient carefully. I kind of outlined that sort of our paradigm is 5-FU oxaliplatin. If that stops working or patients don't tolerate it, then we usually try Taxol with ramucirumab. If that stops working, we often use irinotecan. If that stops working, also even when beyond first treatment, we think about clinical trials. Is there a promising new drug that's being evaluated or a new combination? Are we a candidate for an immunotherapy trial? As part of a clinical trial, can we characterize the cancer for mutations and abnormalities and see whether my cancer might fit a trial where we're looking at a new drug specifically at a target? So it really depends on what the status of things are now, but that kind of is typically the paradigm, is 5-FU oxaliplatin, Taxol, ramucirumab, or irinotecan, clinical trials. Immunotherapy may become available as a later line treatment depending on how current studies are coming out. But clinical trials, if you're a candidate, actually even sometimes a trial will take a patient that's just not tolerating their current treatment. And there are clinical trials available. Many of them are phase 1, new drug trials, or phase 2 studies. But it really depends on what the status is currently.
Thank you.